Grace Resource Ministry welcomes you here tonight, this evening. We have a very important topic to discuss and to hear out from the very best in Raleigh, our own Dr. Yeager, with many years of experience, internal medicine and hospice palliative care with UNC, actually. And Dr. Yeager, you probably tell us more because I don't remember having more than that information about you.
That works.
I want to welcome you. Thank you so much for being here. Appreciate it.
Thank you for having me. Can you hear me okay?
Yes, we can.
Mm-hmm. I have been, as you were saying, I have been a physician in this area now for, I think it's 27 years in the Raleigh area. I worked as a hospitalist and in a clinic for 12 years over at Wake Med, but the past 15 years, I have been at UNC Rex as a palliative care physician. In that position, I am the medical director actually, and I work with patients and families that are dealing with a complicated illness. A certain percentage of those people that I'm helping to care for are actually in the final stages of life. And today I'll be talking to you all about end of life. I'm hoping to share some of what I've learned over the years. I'm very interested in any thoughts you all have or any questions. So please don't hesitate to interrupt me, please.
Good. So sorry to interrupt there. Dr. Yeager, I want to reinstate that you can ask questions in between. You don't have to wait until the end. That's what I understand. Thank you.
Thank you. I am going to be using George and George's 93-year-old grandfather throughout my talk. And that's just so I can have someone as a reference point. So when I refer to George, that's all he is, just someone that I can include in my descriptions of the steps many people go through when they're moving towards the final stage of life. Who will this talk possibly benefit? Well, 1 out of every 1 person will die. So in theory, everyone might benefit from this talk, if not for themselves, then for one of their loved ones. So I do hope you can find something that will be of benefit. During the talk, I'm hoping to touch on palliative care versus hospice. Palliative care is a relatively new medical specialty. It's about 45 years old. It's a specialty just like there are specialties for nephrology, cardiology. It's another type of medicine which requires training. There's board certification in it. It's been growing very fast over the past number of years because the focus of the people that receive palliative care are those people that have complicated medical issues. That's the easiest way to describe who palliative care provides expertise to. So for those folks who have more than one medical issue, they may or may not have a medical issue that is terminal in nature, they would benefit likely from palliative care. I'm also going to be talking about ACP, Advanced Care Planning, that's living wills, healthcare power of attorneys. And then finally, talking about things to recognize when you're caring for a loved one who's in the final stages of life, what to expect. So I'll see if I can go ahead and advance this. Great, okay. So first I'll be talking about palliative care versus hospice. Palliative care services. So I'm going to start with George's grandfather, 93 years old, and recently had a hip fracture. Due to complications from his hip fracture, he is experiencing pain, constipation, and confusion. All of these different symptoms can be addressed by palliative care. And for that reason, his medical community has suggested that he get palliative care services for his grandfather. Other people who commonly receive palliative care are people who might have a cancer diagnosis early on in the diagnosis, or even later when it's more advanced. Patients that have heart failure, another common population of people that frequently benefit from palliative care. So why palliative care? First of all, for the symptom controls, people that have had training in palliative care are experts in controlling issues like pain. So hip pain, they know how to use narcotics, even ibuprofen and Tylenol. That's something that palliative care physicians specialize in. They know how to relieve constipation and assist with confusion. So all those concerns the palliative care services can help with. They will also coordinate care. They will answer questions that George and his grandfather have about where they should go to get the care that they need, perhaps physical therapy, should they go to an acute rehab. All of those issues are things that the palliative care team can talk with them about. As I said, it's a medical specialty. It's available as an inpatient and as an outpatient. When people are seen in the outpatient world, they might be seen maybe weekly, they might be seen monthly. But if a person is in the hospital and palliative care is felt to be beneficial, the palliative care service generally sees people every day and can become a key resource for the patient and family. It is paid for by Medicare, Part B, Medicaid, and insurance, just like any other specialty would be. And again, this just reviews all the different areas that palliative care can help with. Communication. I work in inpatient palliative care, and it's not uncommon for me to reach out to a number of different physicians and make sure that we are honoring a person's wishes and that we're giving them the information that they need. It can be very complicated if a patient has heart failure, kidney failure, perhaps has a lung condition. Trying to bring all those pieces together and understand how best to move forward can be very difficult. Education, management of symptoms, which I mentioned. I wanted to stress again that palliative care can help a person at any point of their illness. If someone is recently diagnosed with an advanced cancer, palliative care can be a benefit. In fact, for adenocarcinoma of the lung, it's been found that palliative care can actually prolong someone's life if they've got adenocarcinoma of the lung and it has metastasized. So it can actually, for that situation in particular, it can actually prolong life. So palliative care is not a service that is provided at necessarily at end of life, though it can be provided at end of life. It's generally given to people who are working on becoming healthier and stronger. It's also provided for people who are not going to survive an illness, but for people that aren't necessarily ready for hospice, they're still processing. So that's palliative care. I'm going to move on to hospice now. In my scenario, George's grandfather recovers from his hip fracture, but in time he actually becomes weak, and George notices that his appetite is not what it was. It is suggested to him that he consider hospice for his grandfather. Most people are more familiar with hospice than they are for palliative care. Hospice, like palliative care, paid for by Medicare, Medicaid, private insurance. Hospice is different in that a physician has to certify that a person has a life expectancy of 6 months or less, given the natural progression of disease. That last part is important because it means that we don't know that a person has a life expectancy of 6 months or less. We can say that most people in that situation would live 6 months or less, but there are plenty of people that live longer than what their hospice diagnosis would have you think. So for instance, I've worked with patients that have been in hospice for a year and a half, even though their life expectancy was thought to be 6 months or less, it actually ended up being much longer than that. When someone requests hospice services, they have made the decision to stop life-prolonging therapy and instead have decided to focus on comfort and quality of life. So they have made a decision that they don't want to do things like do chemotherapy to try and treat a cancer and extend their life. They don't want to have an AICD or a defibrillator to shock their heart if their heart goes into an arrhythmia. Instead, they're focusing on staying home and trying to keep things like shortness of breath, pain, all under the best control possible so they can enjoy their days. The hospice service, unlike palliative care, hospice has a much bigger team. The hospice service has a case manager. They have volunteers who sometimes come and sit with people in their homes, chaplains for spiritual support. They have a 24/7 call system, so you can call them anytime and ask any questions that you have. Hospice also provides medical equipment such as a hospital bed or a bedside commode, a shower chair, and they cover medications as well. A common question that I get is how much bedside care does hospice provide? Hospice does not provide bedside care per se. They might provide an aide who might come twice a week and help with showering or some very basic care in the home, but that would only be for an hour or two. So when someone has hospice care, it's really the caregivers, the family, the loved ones that provide that 24/7 care. Go ahead, please.
Who decides whether to go inpatient or outpatient?
So
or what determines?
With palliative care or with hospice or with both?
Hospice.
Hospice.
Actually,
Yeah, so with palliative care, the palliative care has to be ordered by a doctor, just like any specialty would be ordered in the inpatient world. Outpatient, you can actually ask for it from a palliative care agency, but inpatient, a doctor orders it, and that's how it's decided if it's going to happen inpatient. I'm glad you asked about hospice because I think there's a slide later that comes over this again, but I'm not certain. Hospice can be provided in multiple living situations. The vast majority of hospice is provided in the private home. So a person is living at home or with their loved ones, and hospice comes into the home, and it's usually provided by a nurse. That's the main contact person, and they are seen routinely in the home. Hospice can also be provided in a long-term care bed in a nursing facility. Hospice agencies go into nursing facilities and provide care there as well. The far and away, the most rare situation is for a patient to be cared in a hospice home. You all are probably familiar with the transition hospice home. It used to be Hospice of Wake County. Their facility now has about 30 beds. It is perhaps 1% of the overall, if that, percent of patients that they provide hospice for. So if a patient has a very complicated care plan for hospice, they might go to the hospice home, like the one like Transitions Hospice Home. But the vast majority of people are treated at home because Medicare and insurance will only pay for the hospice home if they meet certain requirements. That's a long answer, but does that answer the question?
Yes, yes, it does. Mm-hmm.
Thank you. Yes, absolutely. I also just wanted to mention that it's not uncommon for people to believe that hospice sedates the people that they're taking care of and immediately goes to narcotic trips. That is not the case at all. In fact, hospice's goal is to start early enough in a person's illness that they can avoid giving any kind of sedation or pain medications as long as possible. And I also just wanted to make sure that people are aware that if you have hospice services, it doesn't mean that you can't go to the emergency room or be admitted to the hospital. That's another common hospice myth.
Oh, I'm glad you said that. That was actually, I had that question. I had written that question up too. And I thought, is it something that I've changed, that hospice, they cannot call 911? Or is that a change?
Yeah, well, to be honest, the hospice agencies prefer if you call them first, but you can always call 911, always. You would get to the emergency room, they would evaluate you. And if you decide at that point that you are still focused on quality of life and being comfortable at the end of life, then the emergency room may need to take care of you and help address some of the symptoms that you're having if you're in a crisis, or you may even need to be admitted to the hospital to receive hospice care if it's complicated enough. But you may also call 911 and go into the emergency room and decide that you've changed your goals of care and you actually don't want hospice anymore. And you can do that too. It's called revoking hospice, and that's completely appropriate. I think that the most important message for me to give is you're always under control, and you can always go to the emergency room and tease things apart there, what your next step in care is if you've ever have concerns and you feel like that's where you need to be. Does that answer your question?
Oh yeah, definitely. Thank you.
Thank you. Again, the shared philosophy of hospice and palliative care, though, are to reduce suffering and improve quality of life. But palliative care, the majority of patients that we see are patients that are not actively dying. They're patients that have a complicated illness for palliative care. This just goes again, I believe you all understand palliative care, any stage of an illness or prognosis, and it can be given at the same time rehab is given, or any kind of treatment that's focused on a person recovering or getting stronger. And then hospice has the prognosis for the natural course of a life expectancy being 6 months or less. Any other questions? Okay.
Good. No one with a question so far? I think they're good.
Okay. I'm going to talk about advanced care planning for a bit now. I have to say, I'm not a lawyer, I'm a physician. So if you have any legal questions or I give any advice that you're at all want follow up on, a lawyer is really your best reference. So George and his grandfather, they decided to discuss hospice as a next step because his grandfather is now getting weaker. He's having loss of appetite, and they're concerned that he is really moving towards end of life. While George and his grandfather are discussing this, George realizes that this is actually the first time he's ever had any discussions about end of life with his grandfather. And in fact, he has not done any kind of advanced care planning to make sure that his grandfather stays in charge, even if he experiences confusion in this last phase of his life. It's very common for people towards the end of life to experience confusion. Over 3/4 of people at the end of life to experience confusion. If a person wants to stay in charge of their medical decisions throughout their life, they should complete advanced care planning. The most common advanced care planning, at least what gets talked about the most, is generally a healthcare power of attorney or a living will. These are all tools to allow a person to guide healthcare, even if the person is incapacitated.
Can they be revoked? Can family member revoke them?
They can revoke them. That's a great point. If someone does an advanced care, does a healthcare power of attorney, and they want to change their healthcare power of attorney, they get a more recent healthcare power of attorney, an up-to-date one that would replace the older healthcare power of attorney. So you can definitely revoke them.
That's sad for the person who wants the, I mean, if someone had decided and then the family comes and revokes, then, I mean, even if it's with an attorney, they still can revoke. It's.
Well, you mean, well, the person who has a healthcare power of attorney can take it away from someone. Like if George's grandfather says that he would like George to be his healthcare power of attorney, the grandfather can change his mind anytime he wants while he is still lucid. If that's what you mean. If you can identify someone as your healthcare power of attorney, or you can sign a living will and then you can change your mind. That's
How about
reasonable.
someone else? Oh, I meant if someone else, can they revoke another? For example, George's son, can he revoke George's will?
That's a great question. No.
Oh, okay.
No, but I'm glad you mentioned that. That's a really great question. So once you've done a healthcare power of attorney, that's a legal document and it stands and it cannot be taken away by another family member.
Okay, good.
So there is, if you don't have a healthcare power of attorney, by North Carolina law, there is an order of who would make decisions for you. And I'll go through that later. But if you have a healthcare power of attorney, that essentially trumps anyone else coming behind and saying that I'm going to make decisions for someone.
Okay.
So examples of decisions that a healthcare power of attorney might make: a healthcare power of attorney could ask to provide guidance if a person would want CPR or not. So if his grandfather's in the hospital and his grandfather gets confused and can't make decisions anymore, then a physician could come to George and say, would your grandfather want CPR? George could be asked for his grandfather, your grandfather's kidneys are failing. Would he agree to dialysis? He's unable to swallow safely. Would your grandfather want us to put a feeding tube in his nose? They're all questions that are pretty routine on a daily basis with that. When I'm working with people in the hospital, all the time I'm asking family members to make decisions for people who are in the hospital and are unable to make decisions for themselves. So it is important to identify a healthcare power of attorney if you have any concerns about who would be guiding your care if you did not have a healthcare power of attorney. And it's extremely important to then tell that healthcare power of attorney what your wishes are. For example, today I took care of a patient and the question of a feeding tube came up, and I was told by the family member of the patient that this patient absolutely would not want a feeding tube no matter what, even if eating food by mouth was going to lead to aspiration and pneumonia, possibly death. I was told by the family that we were not to place a feeding tube. I had another patient today where the family told me that we absolutely should place a feeding tube to prolong life. They told me that for this second patient, this different family, told me that for their loved one, they knew their loved ones, the goal was to live as long as possible. And if that meant a feeding tube, that was completely appropriate. So in both those cases, we were really relying on someone else other than the patient to make decisions.
And does, sorry if I may interrupt, does advanced care planning, is it specific, are there specific areas? I mean, for example, someone who is not in healthcare would not know these specifics about the trach, the G-tube.
Yeah, no, that's a really good point. There's, I don't know if you've heard of 5 wishes. That's something that sort of breaks it down more, specific questions. Some forms for healthcare power of attorney, they do include more information that you can just write in your wishes for certain things like dialysis or tracheostomy. But a lot of times, honestly, it's you're not given any kind of form which specifically takes you through all these different categories. It's more having conversations. It's frequently healthcare power of attorneys just having general conversations with their family members about what has meaning to them, what would they be willing to go through to prolong their life. Does that make sense?
Yes.
but there's also a form I'll show you, which sometimes people use. But for most healthcare power of attorney, you're right. There are not specific categories of things that are brought up. It's more of a general conversation that ends up happening.
Okay.
These are the two, like I said, the two main categories that people are usually familiar with: healthcare power of attorneys and living wills. Mm-hmm. This slide is just to try and help us all remember that the key is to not just identify who you would want to be your healthcare power of attorney, but also to talk to your healthcare power of attorney about your wishes. So many families that I talk to, they don't necessarily know specifics of dialysis or not, but they will know that their loved one would not be willing to live on life support in a nursing facility. That would not be acceptable for them.
Okay.
And it's really passing the baton. That the visual helps me that you're taking your wishes and your ideas of what is best for you and passing it to another person that you trust. If you're able to do a healthcare power of attorney, then that is essentially the person that would make decisions for you. So for George's grandfather, if he did a healthcare power of attorney form, then that person would make his decisions. If a healthcare power of attorney form is not filled by North Carolina law, it goes to the person's spouse if they have one. If the person does not have a spouse, then decisions go to the person's children and the person's parents. So that means if you have an 18-year-old child and you have not filled out a healthcare power of attorney, your 18-year-old child could end up making medical decisions for you.
Wow, it can be a disaster.
Well, I appreciate saying that. I mentioned that because for some people that's reason enough to do a healthcare power of attorney. If your children and your parents aren't available, then your siblings would make your decisions for you. And if your siblings aren't available, then it is, quote, a person with a significant relationship who would know your wishes. So that might be a roommate. It could be a best friend, anyone who can show that they've got an established relationship with you and can act in your best interest, can make decisions that they feel would be consistent with what you would. How to create a healthcare power of attorney. My message with the healthcare power of attorney and a living will are these are not complicated documents to finish. You do not need a lawyer. You should certainly talk to a lawyer if you feel that would be beneficial. I'm not trying to tell you not to, but what you need the form, of course, which you can get off the computer. Then you need 2 witnesses, and they can't be related to you, and they can't be your healthcare provider, and you need a notary. So if you took 2 witnesses, for example, and you had a bank that had a notary that could help you, you could fill the form out right then and there. Same thing with a living will. They're really very easy to fill out. The most complicated part is putting the work in to identify what you want these forms to say, really, what your wishes are. I just wanted to stress that living wills, otherwise known as advanced directives for a natural death, are important documents. I have a living will. I've actually filled a living will out multiple times to make sure that it's up to date and with and reflects what it needs to say to honor my wishes. But living wills are rarely used. Healthcare power of attorneys are frequently used because it's not uncommon for a person to lose capacity to make decisions when they're in the hospital. A living will is only enacted if a person is under a very set situation, such as they have dementia and they are not expected to regain ability to guide care. They have a terminal condition and they are expected to die soon. They are in a vegetative state. I mean, all situations that do not happen very often. A living will is a important document to fill out so your family knows that you have considered there may be situations where someone might need to weigh in and change a medical treatment to make sure that a person isn't put through interventions that are unacceptable. But living wills are not used that often. Healthcare power of attorneys are used quite frequently.
Okay.
Again, that slide just said that living wills are very easy to fill out, essentially, once you put the thought in. And this slide just to stress that really doing advanced care planning, it's a gift to your loved ones. It's providing guidance to your loved ones in during situations where they may be grieving greatly, where they are under a great deal of stress. So it's one of the kindest things you can do for your loved ones, which relates to healthcare.
Did I miss, if I may ask about the advanced care planning? Did I
Yes.
miss it? Did you say where one can, where is it located? I mean, do you take it to the bank like other doctors?
Yeah, so you can, the easiest thing to do, honestly, is to print it off the computer.
Mm-hmm.
You can look up a North Carolina Advanced Directive and print it off the computer.
Okay.
And then you just have to find a notary.
Okay.
So wherever that notary is for you, you know, at the bank, an insurance agent, you know, wherever you normally get your documents notarized, you need 2 witnesses that are unrelated to you to come with you. But if you have the document, a notary, and 2 witnesses, you should be able to complete a healthcare power of attorney or a living will.
And where do you start? I'm trying to think in terms of where someone does their living will or advanced directive, and then they probably go to the hospital. They are, you know, didn't even expect anything.
Yes, no, that's a very good point. Then you would want to tell your loved ones that you have it and make sure your healthcare power of attorney has a copy of the documents.
Oh, I see. Okay.
You want to make sure they've got a copy of the documents. You want to let your loved ones know that the documents exist. And then ideally, you would give it to your primary care physician. A lot of medical practices and hospitals have portals now. And there's even patient portals where you can submit documents like a living will and a healthcare power of attorney.
Oh, I see. Okay. Thank you.
Any other questions? No.
I do.
Oh, please go ahead.
So how would a young person, because you never know, like life can happen, you can have an accident, and you know, you could be in a vegetative
Absolutely.
state. So, like, how would someone who's over the age of 18, you know, go about this so that they're, like you said, like their loved ones and family are like prepared if something was to happen? How does like a young adult would go about that?
Yeah, no, that's a great point. And honestly, it's the same process as you would for an older person. So you would want to do the same thing. You print the documents. You can have 2 fellow young adults be your witnesses. You can have a young person be your healthcare power of attorney if you want. If you have concerns, if you're a young adult, it would probably be your parents. That would be your medical decision maker if you don't fill out a healthcare power of attorney. So if someone is, 21, 22, for example, if they do have children, they would be too young to fill that role. So by North Carolina law, it would automatically go to that person's parents. So if they felt comfortable with their parent making decisions and there's nothing to do, if they felt that there was somebody else that should fill that role, then the person should fill out a healthcare power of attorney form. So that person is identified who would be there. So maybe it's a sibling, for example. So it's the same thing, get a notary, 2 witnesses, and get the form filled out wherever a notary is. You should be able to do that. And as far as particulars are, it's talking to your healthcare power of attorney person. Now there's another form called a most form, which we'll talk to in a little bit, which has more detail. I have mixed feelings, and I think the forms can be very helpful for conversations. I think they can be confusing sometimes when people fill them out, but I'll talk more about that when we get to the most form. But does that answer your question?
Yeah, with life and everything, you never know what could happen. And so I just wanted to know, like, how would it, I know it concerns like the elderly, but it could also happen to a young person. So I just want to know how
Yeah.
to
Well,
maneuver around that situation.
I think that's a valid question, because I will tell you, I've been doing this in the hospital for like 15 years. And when tragic things happen to a young person, it's often, not always, but it's often more like an accident or something as opposed to a terminal illness. And it's not unusual for young people to have more aggressive measures happen, and for more like prolonged life support and what have you. So if that's what you're speaking of, if that's something that you would be concerned about, it would be important for you to have a healthcare power of attorney who you feel could honor those wishes if something were to happen and you would have concerns about putting that burden on your parents to follow your wishes. Does that make sense?
Yes. Yes. Thank you so much.
Mm-hmm. I think that's a very tough situation when you're young. You need to really document and have conversations if that's something that concerns you. A DNR order, I wanted to mention these. It's not advanced care planning. A DNR order is a physician created order where a person requests that they not receive CPR if they have an arrest, and they would prefer to be able to pass to die rather than go through CPR. It stays in the possession of a patient. So if an individual has a DNR, it stays with them at a nursing home, or if they're living at home and they've got a DNR, it would actually be in their home with them. And I have an example of this. I hope, there it is. I don't know if you all are familiar with this, but that's an order that if for instance, someone had a terminal event in their home and EMS was called, EMS would come, but they would not perform CPR if they were shown this doctor's order. Just to stress that a DNR does not mean do not treat. It's specific to CPR. This is the most form that I was talking about. And it's a form that's supposed to allow people to give more specific guidance on what they would or would not want if they were to become seriously ill and they lost capacity to guide care. A lot of people are not familiar with this form, but it includes guidance with things, whether you would want tube feeds, whether you would even want antibiotics or IV fluids. There's a lot of detail in it. I just think it requires a significant amount of time to go through, and it really needs to be done with somebody who has a lot of medical information about what it means to say that you would not want these interventions. But it's another tool that can help provide guidance if you're not able to. It can also be used as a tool to help with a conversation when you're talking to your healthcare power of attorney about what might or might not be acceptable for you. Any questions on those pieces before I go to the last part?
I was talking to myself, I didn't realize I was muted. Is that form online too?
Is that what? Form
The
online?
form.
No, it is not. That's a great question. It is not, because it needs to be signed by a physician or a nurse practitioner. So you can find examples online,
Okay.
but like the yellow, it's called a goldenrod, that goldenrod form, those are all forms that you would have to, that are kept by medical facilities because it requires a signature of a medical professional. But you can look at it online and see what the kind of questions are.
Okay, thank you.
So the final section I wanted to talk about is what to expect. What are some of the transitions that happen when people are going through the final phase of life? So going back to George's grandfather, in this scenario, he recovers from his hip fracture, but he remains weak. He loses his appetite. He develops pneumonia. George is asked at that point, as George has become his healthcare power of attorney, if his grandfather would want to be placed on life support or transition to hospice. Again, just mentioning how important a healthcare power of attorney and a living will is. George makes the decision that his grandfather would want hospice at this point in his life. This slide to just point out again the role that hospice plays in the final stage of life. In survey after survey has shown that the majority of people would prefer to be able to die in their own homes. We have learned that the best way for that to happen is to have the care of hospice. If not, the risk of dying in a hospital greatly increases. So again, just a recommendation to involve hospice for those people who would prioritize being able to die in their own home. So what can George expect? I mentioned before that in the weeks to days before death, confusion is very common. Not necessarily agitation, but it is very common for people who are in the final stage of life to have some element of confusion. It is also very common for people at the end of life to have a decrease in appetite. People that are going through this phase of life may recognize that it's time to eat. They may remember favorite meals. I have many times had families that have brought loved ones special meals in the hospital. And while the person is grateful for the meal and might have a bite or two, ultimately, even if they've requested the meal, it is very common for them not to eat the meal as their body is shutting down. Nutrition is not something that they really desire at this point. It's also not unusual in the final weeks towards death for people to talk to their loved ones who have passed already, or to even see their loved ones in the room with them. All of this seems to be in preparation for the transition to death. I wanted to mention rallies because I feel like it's not uncommon for this to be confusing to loved ones. Goodness knows it's also confusing to medical providers frequently. But a rally is sort of a surge of energy at the end of life. It usually happens, when I've seen it in the literature, what I've read is within days of someone passing. But a person, for reasons that aren't understood, can suddenly regain an appetite. They can become more conversant. They can become more alert. It may last for a day. It may last for less than a day. And then the person quickly begins their transition towards death. But I think it bears mentioning because of the confusion that it can cause.
What causes the confusion?
You know, that's a great question. I think of it being these These people that we're caring for, usually they're not eating, they're not drinking. So the dehydration and the lack of nutrition, they're frequently not perfusing their brain the way they normally would. So for any number of reasons, they're not operating in a way that's conducive to being sharp and being able to interact. It's all part of the process. And I say that, and it's not that I think that, providing fluids or nutrition would change things, but it's all part of that process of going through a period of time where you're just not interested in eating and drinking the way you normally would.
And is congestion from lack of movement?
So the congestion is usually that's more in the hours or days prior to death. It's it's when the muscles in the esophagus lose the ability to swallow. That's, that's part because of the brain function not being what it was, but it's also because the body is weakening and a person can't handle their secretions. So another common, it's people commonly refer to it as a death rattle. And it's all part of the dying process. It does not seem to bother the person going through the congestion, but it can be very distressing to loved ones. So there are medications that we can give to try and decrease that sound, but just the importance of recognizing it, for most people, I would say it's just part of the dying process. Also, as part of the dying process is skin modeling, where the skin can take more of a purple or a blue tone to it, especially in the hands and the feet, and can become cooler. That usually happens in the hours, the days before death. And there can also be significant changes in breathing patterns, especially long periods. It can be a minute or two where someone does not take a breath. They have periods of apnea. And it can appear that a person has passed, but really they're just having this breathing that is extremely slow. There can also be a breathing pattern that's mixed with very slow breaths combined with very rapid breathing. But all of these are the normal process of a body transitioning. I also wanted to mention at the bedside, when caring for someone who is dying, things that I've learned over the years and honestly have frequently been taught by excellent nurses. Touch may or may not be helpful. For some people who are dying, it can actually be an annoyance to have the arm rubbed. I've seen people that mean well, but are perhaps not helping with comfort when they are constantly rubbing a person's arm or leg. You may want to just a gentle touch is the way most people seem to get comfort. Moistening lips gives great relief, has been my experience with the people I care for. A small sponge to moisten the inside of the mouth, but usually people cannot actually swallow and drink fluids at the very end of life. Always gentle cleaning of the face and the body in general. We prioritize that just as we would for any patient. Clean sheets, clean nightgowns, gentle cleaning. Hearing is the last sense that is thought to be lost. So wanted to remind everyone that, and medical profession is not always good about this, nothing should be said in the room of a person who is dying that you would not want that person to hear. If you're with someone who is end of life, even if it appears they can't hear anything, they should also be treated with great dignity and as if they can hear everything in that room. It should be a quiet room, but my experience is that people who are dying are often appear more relaxed if they can hear familiar voices in the room. I've been in many rooms where families are gently sharing stories about their loved ones. And it seems to, my experience is it brings the people I'm caring for great peace to have loved ones sharing stories in the room. And as I said before, it's not uncommon for people to see their loved ones who have already passed. I didn't put a slide in regarding grief, but in my story with George, I like to think that his loved ones, his family and friends all surrounded him and gave him support in the weeks and the months that followed the passing of his grandfather. That's how my story ends for George and his grandfather. What questions do you have about anything that I shared with you today?
Wow. Great information. I was asking the questions throughout. Let's see whether someone else has a question. But I think the only question, you look like you answered all my questions during your presentation.
Oh, good. That's good.
I'm getting everyone else gets ready with theirs. Let's see what was left. It's like, okay, if we kind of switch roles and assume now, no, George is the one taking care of, no, George's son is the one who is laying down there with the last days or the last hours of their death. Okay, is there another way? Is there a way that they communicate so that one can know? For example, most usually at those days, the person is not communicating.
Mm-hmm.
Is there a way that a certain way that one would know this is what they mean, this is what they want?
That is such a great question because it comes up all the time, and it is so sad and so frustrating because once a person gets to that point and they're confused, they are unable to provide guidance. It happens again and again because now not only are they confused, the questions that you want to ask them are incredibly complicated. You know, it's one thing if someone's mildly confused, but you want to ask them a simple question like, do you want chocolate or vanilla ice cream? And maybe they're slightly confused, but it's okay because it's a simple question. But instead, you've got somebody who, even if they're mildly confused, now you're asking them, would you want to be put on life support if we thought you might need a tracheostomy and then you might need to go to rehab and perhaps in a month or two, you'd be able to come off the ventilator, but you might need to live in a nursing facility for the rest of your life. Do you know what I mean? They're so complicated. So once someone starts to get confused, you've lost your opportunity. I'm sorry.
Okay. So that's where the power of attorney comes in. What do you call them? Healthcare power of attorney, yeah.
Healthcare power of attorney, and that's why you want to talk to them before. I have a friend who made me her healthcare power of attorney, and one of the pieces of information she gave me, if I ever had to make a decision, she said to me, if you think that this is not something I want to go through, I want you to feel confident that you shouldn't put me through it. And that's a great piece of, you know what I mean? I'm not saying that that's something everyone should give as advice. I don't mean to imply that at all. But I just feel like there's things you can say. I've had people say, my loved one told me they don't want to spend their life in a nursing facility. So if you think this is going to end up with them being in a nursing facility for the rest of their life, then don't do this to my loved one. I'm not saying that's right or wrong, but that's a piece of advice. I've had people tell me, I don't want to go on dialysis. I've had people tell me that their loved one does not want to go on dialysis because they had someone else who was on dialysis and they were miserable. I've had more people tell me that they would go on dialysis. Their loved one wants to go on dialysis because they know all about it and they think they could tolerate it. Am I confusing you, or do you understand what I'm saying?
Yeah.
These people.
Yeah, I understand. All right. What other questions do we have out there? Look like I'm the only one who has been talking. Anyone else with a question?
Can you hear me?
Yes.
Hello. Yeah, I have a question.
Yes.
So if you have the power of attorney and this person doesn't want the CPR, they want to go,
Uh-huh.
with the power of attorney, is there anything to quicken their going if they really want to go?
That's a really good question. So the power of attorney is only enacted. It only becomes, it's only used if the person cannot guide their own care. If a person can guide their own care, then a power of attorney has no role at all. It's only becomes important if a person can't guide their own care. So that's one point I wanted to make. The other point I wanted to make is, I think what you're saying is, for instance, if there was a person in the ICU and they could not make their own decisions, but the power of attorney knew that they would not want CPR. So the power of attorney would be able to tell the medical team, do not do CPR on this person. On their power of attorney, do not do CPR if their heart stops. Now, if that power of attorney also knew that the person would not want to be on a ventilator or would not want tube feeds, they could say, do not do those things. These are things that I know this person would not agree to, and they could stop those things. And that would cause them to pass earlier. But if you're honoring their wishes, then you're honoring their wishes. Is that what you're saying? Are there things you could stop CPR? Yes. So
yes. And if the person wants to go, you know, let's say their wish is they want to die quickly. They don't want the ventilator, they don't want anything. This has happened and their wish is to go. Can their going be quickened? Yeah.
So you can stop, I think I understand you. You can stop things that have been started if they're not consistent with the person's wishes. You can stop a ventilator, you can stop dialysis. You can't give medications to hasten death.
Okay.
So yeah, you can't do that. Not in North Carolina, you can't. You can only respond to symptoms. So, if you stopped a ventilator, you could give a narcotic to take away shortness of breath, but you couldn't give a narcotic to hasten death.
Okay, got you. Thanks.
Yes, absolutely. It's a great question.
Or one can take them out of state.
Okay.
No, I'm just kidding.
I don't know if that would work, but
I'm just kidding. But to that, I wasn't want to add, and I believe you mentioned it, that there's a belief out there, or is a myth that hospice, when one goes to hospice, that's it, that they're given medications to hasten death. And I know you mentioned that. Is that correct? I mean, that's a myth.
That's a myth, right? Legally, hospice cannot do that. We just can't practice medicine that way. We can only give narcotics or sedatives if it is specifically being used to treat a symptom.
Is that
like shortness of breath or anxiety?
Is that also in the home setting? Because I know, I guess in the hospital, I think we are a little bit more careful, but is that true also in the home setting?
It is. Oh, okay. That's the way that medicine is to be given, only in response to a symptom, in the home setting and any setting.
Any other questions? Thank you. Any other questions? Or comment? At least I learned myself, I learned a lot. Go ahead.
I had just one comment. This was like eye-opening, for like someone who's like a young adult and getting like a power of attorney and a health power of attorney and all these decisions. Thank you for explaining more of like what goes on in the other practices, because normally we don't hear what happens in those practices. So this was like an eye opener for me. So thank you so much, Ms. Ann and Ms. Eva.
Thank you. Thank you for saying that. I greatly appreciate it. I've really enjoyed talking with you all and appreciate the invitation, Eva.
You're welcome. Thank you. This is it's sensitive but very important information that we gets left out all the time. Any other questions or comment? Maybe before we finish, I can ask about the advanced care planning or advanced directives, the paperwork. Is it indefinite? Like, is it ever, does anything ever change, or one can just do it and it stays the same?
Yeah, that's yeah. I can't tell you. I mean, we've had living wills and healthcare power. In theory, you can do it once and be done. I do think it's something that's worth revisiting, because if you have a document, it's just that much stronger.
Yeah.
That that it was given recent thought, that it was recently reviewed. So yeah, does that make sense? I mean, it should be honored, but if you pull out a healthcare power of attorney that's 18 years old, if it's going to be questioned, it'll be questioned a lot faster than one that's 2 years old.
Oh, I see. Okay.
Do you know what I mean? But the legal document shouldn't change. I mean, could it change that you need one witness instead of two, or vice versa? That's possible. But my understanding, again, I'm not a lawyer, is if it was done in good faith, that it should hold on its own. But I do think it's smart to try and redo it and have one that's more recent, just safer.
Okay. All right. Thank you so much. Thank you so much.
Thank you.
Any other questions before we close?
Can I ask this one, as Miss Eva had already asked, that if I'm making my decisions about what is going to happen, and then when I advance in age, or I get sick, and the power of attorney does not have any more directives, is there any change the doctor can do which can direct the end of life for me?
You mean, could the doctor give guidance to your healthcare power of attorney? Because the doctor could do that.
Yes, that's what I'm asking.
Yes, the doctor could do that. The doctor could provide guidance to your healthcare power of attorney. And I think, thank you for asking that, because I think you're bringing up a very good point. You have to really be able to trust your healthcare power of attorney, because you're not going to be able to give guidance on every single issue.
Yes.
So I think so you're right. What you really need to do is know that your healthcare power of attorney is going to have your best interest at heart. Yes. So for instance, sometimes I have people that tell me that they've decided they never ever want to have tube feeds. That's something they've decided. Well, that's a very individual decision, but I do wonder, sometimes it's good to keep options open. Maybe it's okay to have tube feeds if it was something reversible, and maybe the tube feeds would just be for a week, and then you would be able to start taking nutrition by mouth again. So it's good for your healthcare power of attorney to have some leeway where they can make decisions, and they can talk to your doctors or nurse practitioners, physician's assistants. So I think your point is well made.
Very good. Anyone else before we close? You don't want to close anyone out.
Hey everyone, I have a question. This is Maureen, and I joined in the middle, so I'm not sure whether you discussed this or it's part of the discussion, but can you tell me the difference between hospice care and palliative? I know it's a whole big discussion, but just the highlights.
Sure, and I can just give you the highlights. I think that the most important piece is that hospice is for people that have a life expectancy, for the natural progression of the disease, to have a life expectancy of 6 months or less, and their focus is just on quality of life. That's what they're doing, quality, not quantity. Palliative care can happen at any point in an illness. Palliative care can be offered when someone has a recent diagnosis of cancer and they're getting very aggressive chemotherapy and radiation therapy. Palliative care can help them have symptom control, can help them reevaluate their goals, can help with education. It can happen at, if somebody has very advanced heart failure, but they're not ready for hospice, they still want to come back and forth to the hospital, but they're also concerned that they're getting closer to end of life. Palliative care can happen in that situation too. To get palliative care, you just have to have a complicated illness that requires more expertise with medical issues. Does that answer?
Yes.
That's confusing. Okay.
And
And a
Maureen,
quick one.
I was going to make a comment. Maureen, this is on Facebook too, and Dr. Yeager had covered the whole difference, had gone through the differences. So you can, if you can go back, maybe can help you more.
Perfect. Thank you so much.
Thank you.
Oh, I thought you had another question, Maureen, or you're good?
I had another one, but if it was covered, I think I can go back and look.
You're welcome to ask too. I mean, whatever works for you.
Go ahead and ask.
I was just curious to know, because I think North Carolina, they always say, I think for hospice care, it's up to 6 months, if I'm not wrong. So what happens when, let's say, that person you're expecting, they'll die within 6 months, they don't, do they go back and reevaluate?
Yes, that happens all the time. I think the longest I've seen someone stay on hospice is 1.5 years, I think, because they didn't die in 6 months as expected, and hospice went out and evaluated them again, and they said, oh, we think you'll die in 6 months, but they didn't die in 6 months. So hospice them again and said, we think you'll die in 6 months. So you can get hospice extended over and over again, as long as it would seem that your life expectancy is 6 months. But evaluations all the time. Graduate hospice, I have a lot of patients that were told they had 6 months to live, but instead they got stronger, and hospice said, we can't take care of you anymore. You're too strong. You're too healthy.
I like that.
Yeah, I like that too.
Oh. So it's every 6 months, hospice has to be 6 months, and after that, you're gonna discharge, or they do a reassessment.
Or they can renew. Mm-hmm.
Renew. Okay.
You actually, yes, patients actually get evaluated more frequently than that. It's a lot of detail, but a person actually gets reevaluated at 3 months, and then they get evaluated again at 3 months. But I think the important information, I think, is that hospice can go on for a long time, but you also graduate from hospice.
Oh, I see. I like the graduation part of it.
Yes.
Any other?
Yes. The good graduation.
Any other questions? You don't want Dr. Yeager to fall asleep right here on the. It's been a long day for you.
No, it's good. It's really nice. Oh,
good. Thank you. We appreciate you. Anyone else? Or okay. I think they're satisfied. You give us a lot of information, good information, and we can go back on Facebook, and if anyone needs more information, that needs a clip of it, I can send there. I know it's a recording. Yes. So we want to thank you so much for your time. Thank you for all the information. My goodness, I couldn't even imagine you can be here tonight because of how busy I know you are.